1, 2.
Yeah,
So it just
perfect.
takes it a second.
Let's go ahead and get started. I'm not sure I need this, but my wife says I don't project well enough, so I'll continue to use it. Welcome to tonight's Mini Med School. My name is Dan Foster, if you don't know me, and I'm delighted to be the moderator for tonight's presentation on allergy and asthma, the basics. I think 101 is what, I don't think we did enough marketing. I think this is a great topic, but we have some great speakers, and hopefully those who are here will find this quite worthwhile. A little background history. Many of you may remember that this program, the Mini Med School events, go back many years, probably 30 years ago at least. Dr. Joe Skaggs ran these. He's the one who started the programs. And then with Dr. Skaggs passing, sort of went into hibernation, and they were resumed about 10 years ago. And Dr. Skaggs, for those of you who don't remember him, was Chief of Medical Affairs for a long time at Charleston Area Medical Center. A few housekeeping matters for those here. The bathrooms are right outside for the door there, and obviously, hopefully, many of you have partaken of the food. We have exhibits in the back, and there's some swag from Vandalia Health and the Foundation and the Cancer Center that you're certainly welcome to, and certainly feel free to go back and get the food during the middle of the presentations if you wish. We're going to have two speakers, and the speakers will speak for 20 to 30 minutes. Do not interrupt them. What we will do is questions. If you have questions, I don't know if you've got cards, or they gave you cards to write questions. Just raise your hand if you have a question, and somebody will pick it up. And then at the end of the presentations, we'll have a little panel, and the two presenters will sit down there, and we'll ask the questions. I'll read them out to them, and a lot of them conceivably could be similar. Let's see, the survey, did you all get surveys, or will they get them when they leave? Okay, please fill those out. Those help us determine what to do in the future, and also refine the processes that exist now. I certainly want to, before we get started, I want to thank our major sponsor for these events, the CMC Foundation, and its President, Brian Cummings. They've been doing this for at least the last 10 years since I've been involved. With that being said, it's my pleasure to introduce our two speakers. First is going to be Dr. James Clark. I think I know him as Jim. I believe he was probably a resident when I was hanging around here doing surgery years ago. Dr. Clark is a native of St. Albans, and he obtained his undergraduate degree from WVU, then received his MD degree from Marshall. He then completed an internal medicine residency at CMC, and then his final educational component was an allergy fellowship at the University of Tennessee. So he made the circuit, but we're glad he came back to West Virginia, where his roots certainly were. He has been practicing allergy and immunology in West Virginia for nearly 30 years. It's hard to believe, given the fact that he was a resident when I was around here. He has offices in both Charleston and Taze Valley. His professional interests include allergies and asthma, urticaria, eczema, and primary immunodeficiency. He could probably explain those to you better than I will, so I won't try to get into the weeds with that. Personally, he is married and has 5 adult children and 5 grandchildren. And his most enjoyable non-professional pursuits are traveling with his family, boating at Smith Mountain Lake, and hunting and fishing in Greenbrier County. So I give you Dr. James Clark. He's going to tell us about allergies and a few other associated things. Thank you.
Thank you, Dan. Very nice. Well, I want to thank everybody for coming out tonight and hope our AV stuff works. So like Dr. Foster said, I've been doing allergy for a long time, and I like talking about allergy, so this should be pretty easy. What are we going to talk about tonight? allergic rhinitis, or what everybody calls allergies, is the nose problem. We're going to talk about allergies, and then we're also going to relate that a little bit to asthma. And at the end, if there's other allergic questions you have about hives or contact dermatitis or anything like that, please, write those down and we'll talk about it. But, how do allergies happen? We're going to talk about that. What are the everyday triggers? We're going to find out how we diagnose allergies. And then talk about the treatments. There's a lot of different treatments out there, and every time you turn around, they're coming up with something new. So pretty interesting stuff out there in the world of allergy. And then we're going to talk about how allergies connect to asthma, and that is the lung connection. It's important to keep in mind with asthma that there's not just allergic asthma, but there's also non-allergic asthma. You don't have to be allergic to have asthma. Talk about how we diagnose and treat asthma, and then realize that there's a lot of people that have both of these, and with the right treatment, right diagnosis and treatment, you can certainly live a good life with that. So allergic rhinitis, the old term people still use today is hay fever, although it's not really hay and it's not really a fever. Hay is a grass, and there are certain times of the year when people cut hay, and that happens to be grass pollen season or in the fall, ragweed season. So really, it means hay fever is a better term for that is seasonal allergies. What happens? We're going to see a picture here in a minute, but essentially your immune system is overacting to these particles that are really harmless. Pollens, pet dander, mold spores for the most part are harmless, dust mites. But if your immune system is reacting to those, then it can cause all these symptoms that we see for allergies. So with allergic rhinitis, it affects the nose, the eyes, and the throat. Kind of anywhere you have these cells called mast cells, and we're going to see a picture of mast cells in a minute. Mast cells are where the allergy antibody attaches to, and people with allergic rhinitis or hay fever, pollen allergies, that the eyes are loaded with mast cells and IgE, the allergic antibody. So being outside at this time of year, it can really cause a lot of allergy symptoms, eye symptoms. And so there's really two types of allergies. There's seasonal allergic rhinitis. That's the pollens primarily, pollens and molds. Early spring is tree pollen. Late spring and summer is grass pollen. You have a lot of overlap. We're kind of in that period right now, so that's why it's really bad for a lot of people. Weed pollens are more in the fall, like ragweed pollen allergy. And then molds, people think, the pollens are a big deal, but where I trained, we did the pollen and the mold count, and the mold count always blew the pollen count away. So the minute it warms up outside in the spring, the mold count picks up there, and it grows higher through the summer and even higher in the fall, gets cold outside and drops off again. So in this part of the country, lots of mold, and mold can be a pretty big allergen. So the other thing about allergies is it is a genetic condition, and you have to be genetically predisposed. So it does run in families. So when you're board certified as an allergist, you see both adult and pediatrics because of that. So you might say, well, people with colds will sneeze, so how do you know that it's allergies? Well, if any of you have allergies or know people that are allergic, with the sneezing part of allergies, it's bursts of sneezing, several times in a row. Some people will come in and say, I sneezed 20 times in a row. And my neighbor does that when he cuts the grass. So it's sneezing spells. The other real hallmark of allergies is stuffy, alternating with runny nose. People are walking around with their nose stuffy like this, and then it's running, and they have a tissue. And that's all because of the allergic response, the inflammation that's going on in there, causing the congestion and what we call rhinorrhea, or a drippy, runny nose. Now, you've all heard about the allergic salute. That's this thing here. And what that is, histamine, which is released during an allergic response, is an itchy substance. It hits an itch receptor and makes your nose itch, makes your eyes itch, makes the roof of your mouth itch. And I don't know if you've ever heard this, but people, my daughter is one of them, if they're having an allergy attack, they try to satisfy that itch on the roof of their mouth, and they make this crazy sound like, and drives their loved ones nuts. But yeah, so that itching of the soft palate is what's called a sine qua non of allergy. The only thing that can cause that is allergic rhinitis. So Itching. If someone's having a lot of itching, they usually have allergies. I mentioned that the eyes, the conjunctiva, are loaded with these mast cells and allergy antibody. So if you come in contact with those allergens, like the pollen outside now, you're going to get the red eyes, the itchy, watery eyes. Postnasal drip. A lot of people with allergies will complain of this drainage going down the back of their throat, and they clear their throat a lot. Sometimes at night they're coughing because of that drainage too. So that's another big thing. Now, we've all heard of the allergic shiners, and allergic shiners are these dark circles that can appear under the eyes of oftentimes kids, but sometimes adults, if there's nasal congestion. And allergies, if you poll allergy patients, nasal congestion is primarily the most common trigger or most common symptom they have that they don't like is that congestion. Now chronic sinusitis can also give you that congestion and cause those dark circles too. There's one finding that you can look at a patient from across the room and say that person has allergies. And that's when they've done this allergic salute so much, they get a little crease over the bridge of their nose, and that's called a transverse nasal crease. And sometimes that's permanent if you do it long enough. So you ever spot somebody that's got this crease right here, they've got allergies. The allergic shiners, it can be allergies or sinusitis. What other ways can you help differentiate allergies from a cold, for instance? Well, it's the duration of symptoms. Colds last maybe 4 or 5 days. Allergies are weeks, oftentimes. Sometimes allergies lead into chronic sinusitis, and that can be months and years, believe it or not. So colds are quick to act and quick to go away, and allergies are typically not. So this is the allergic response. Print's a little small on this, but essentially it involves your immune system. We all hear about the T cells. The T cells are sort of the conductor of the whole orchestra that is the immune system. So the way allergies work is, number one, you have to be genetically predisposed. About 30% of people in the U.S. are genetically predisposed to have allergies. Number two, you have to be exposed to the allergen. And in this picture, off to the left-hand side, those little spiky things, those are ragweed pollens. That's what they've used for demonstration here. And it shows the ragweed pollens, then an arrow over to the B cell. The way this actually works is the T cells are presented this allergen once you breathe it into your nose or in your lungs. They are presented by a special immune cell, and then that turns that T cell on and sends signals to the B cell to start making antibody that matches or binds to that ragweed pollen or whatever the other allergen is. And so you can see these little Y-shaped things that are on the other side of the arrow. That's IgE, or immunoglobulin E. IgE is the allergic antibody. So when we're doing allergy tests, we check for IgE, whether it be in the blood. We can do blood allergy tests. We can do skin tests. The way we can do skin tests is this big round thing that has all the Y's or the IgE on it is known as a mast cell. Mast cells are storehouses of histamine and other mediators or other chemicals that, when released, lead to this allergic response. So at the first exposure to this allergen, your T cells tell your B cells to make IgE, the Y's. It goes and rests on the surface of mast cells. Those mast cells are throughout your body. They're in your skin. They're in your eyes. They're in your nose. They're in your throat. They're in your lungs. There's a similar cell called a basophil that's in your blood that has that IgE on it. And so once that IgE rests on the surface of mast cell, it just kind of sits there and waits to be exposed to that allergen again. So maybe next ragweed season, you go out, ragweed comes along, you can see the ragweed on the lower part of the slide coming in contact with those Y's on the mast cell. And the way this works is that ragweed pollen or whatever the allergen is has to cross-bridge two of these little Y's. And if it does that, that creates what's called membrane transformation, but it changes the structure of the membrane of that mast cell and out dumps histamine, leukotrienes, all sorts of other mediators that lead to the allergic response. And it happens pretty quick. That's called the immediate allergic response. And so if you are allergic to cats and you go in someone's house that has cats, you're sneezing and rubbing your eyes within minutes because this is a really quick response. Well, what does that histamine do when it's released? Well, histamine, which is the main thing that's found in the mast cells, increases permeability or leakiness of blood vessels. So that's the runny nose in the nose. It causes the blood vessels to dilate, and that's the congestion. So this is the inflammation that's coming from the allergy response. leading to all these different allergy symptoms that we see. Now, this is allergies, but you can say something very similar is going on in the lungs with asthma. It's a very similar process. So, just to kind of summarize that, first exposure, body makes IgE antibodies, and that's the Y-shaped antibodies, and those are very specific. It's kind of like a lock and key hypothesis for whatever you're allergic to. And then the second is the IgE sticks to those mast cells, and they kind of camp out and wait to be exposed again to that allergen. When they're exposed, the mast cells explode, release the histamine, leukotrienes, other mediators, leading to what we know as allergy, which is histamine-mediated things. Histamine hits the itch receptor, so you get all this itching. It causes the blood vessels to swell and get leaky, so you get the mucus and you get the itchiness. So that is the allergic response. It's kind of technical, but when we treat allergies, we're kind of trying to hit different pathways of this mechanism, and we'll talk about those medicines. So, common everyday allergens. We know pollen's a biggie, and I mentioned tree pollen springtime. The minute it starts to warm up outside and you start seeing the yellow stuff settling out on people's cars, that's tree pollen. Then we get into the time period we are now where we have overlap between tree and grass pollen, and then weed pollens are in the fall. I have some patients come in and they're like, this tree's driving me nuts, I'm going to cut it down. I'm like, I wouldn't cut that tree down. Why? Well, keep in mind that the pollen that you're exposed to probably blew from a mile or two away. It doesn't have to be right in your yard, the tree that's there. So just being outside during the times of the year when those pollens are up, you're going to be exposed to that stuff, whether you have trees in your yard or not. It's important to keep in mind that pollen is much higher in the morning than it is in the evening. So if you want to do outdoor activities and you have pollen allergy, you want to do it in the evening, because by that point the pollen has kind of dropped off quite a bit. But pollen's not the only allergen. Probably the most common allergen that I see on skin tests is dust mites. And dust mites are microscopic creatures that live in our home, and they eat our dead skin cells. And that's not the worst of it. The worst of it is it's their waste pellet that they produce that collects in the carpet, upholstery, bedding, and we breathe that in, and that's what causes the allergen. So they're about the size, the waste pellets that they produce are about the size of a pollen grain. So there's a really interesting researcher and physician, Dr. Thomas Platts Mills at UVA, and he's known as the dust mite guru. And he does a very interesting talk how he relates the rise in dust mite allergy to the carpet industry in the United States. Used to be, way back in the day, it was almost sacrilegious if you had a carpet in your house that didn't get taken out and beat with a rug beater every so often. And then along came the carpet industry and said, you have to have wall-to-wall carpet. And everybody did. And then the carpets never got taken out anymore. And it's hard to believe how much dust mite allergen can accumulate in those areas. So he does a much better job than I do of explaining it, but it's, wall-to-wall carpet, if you're dust mite allergic, it's bad. Dust mites also like feathers. Feathers and skin cells are fairly similar. They're closely made out of the same stuff. So feather pillows, feather bedding, if you think you're allergic to feathers, it's the dust mites that's in the feathers. Now, pet dander. Pet dander probably helps keep me in business. I don't know how many times I've told people to get rid of their pets, which I gave up on that a long time ago, actually. Nobody gets rid of their pets, especially not cats. So, and cat dander can be pretty tough to deal with. It's a very small allergen. It's not like human dander. It's a protein called FeLD1 that's in their saliva. It gets deposited on fur when they lick themselves. It flakes off and becomes airborne, and it's weightless, so it's just floating around in the house. Way too small to be trapped by furnace filters. So to trap that, you know, cats don't like a bath, but some do. I have some patients that bathe their cats, but they have wipes that you can wipe them down with, which helps. Keeping them out of the bedroom is helpful. Running a HEPA filter, HEPA filter, will help trap that airborne pet dander. Using a HEPA vacuum cleaner, all those things are helpful when it comes to cat dander. And actually, Purina put a lot of money and effort into developing a cat food that has an antibody against FeLD1 in it. So when they eat the cat food, it binds us in the saliva, it keeps it from being deposited on the fur, and it does help cut down cat dander quite a bit. So a lot of different things that you can do. When it comes to molds, like I said, most mold spores are outside. If you've got dampness or a moisture issue in the house, you want to make sure that gets remediated because Molds can be a bad thing in the house. It's just not good. So you want to make sure there's no mold issues inside. So when it comes to outdoor allergens, like the perennial allergens, air conditioner is your best friend, really. You want to run your air conditioner. You want to keep your windows closed. If you are doing outdoor activities, I'm pretty allergic to grass myself, and I cut the grass, and the minute I'm finished, I go take a shower. And if I don't, later on that day, I'm paying the price. That immediate allergic response has now led to this delayed allergic response, and now I'm stuffy, and my eyes are red and itchy. So if you do outdoor activities and you're getting sort of loaded with pollen, it's good to come in and take a shower, wash your hair, change your clothes, things like that. Now, the bottom here talks about cleaning agents and other things. And smoke. Are those allergens? No, they're not allergens. They are what we call non-specific respiratory irritants. So I hear this a lot. People that are allergic or asthmatic, and they're walking down the detergent aisle of the grocery store, and they start to sneeze or they start to wheeze. Are they allergic to that smell that you get in that aisle? No, it's just the strong scent. That's what we know is known as a non-specific respiratory irritant. Smoke is one of those. Cold air is one of those. Dry air is one of those. So those are all things that are a sign that you're kind of inflamed if these things are bothering you. Okay, so if we're going to diagnose allergic rhinitis, obviously it's good to take a history because our testing is typically geared towards what we think they're allergic to. And so when they come in, we want to know what their symptoms are. Do they have these sneezing spells? Are they stuffy a lot? Do they cough a lot? Is this a seasonal thing? Does this happen every year in September? Which would suggest maybe ragweed allergy. Is it just at grandma's house where the cat is? Stuff like that. So getting a good detailed history is important. I mentioned with testing, most of the time we do allergy testing by scratch test, where we have these plastic applicators that are like toothpicks. Each has an allergen, a different allergen on the surface. It scratches the epicutaneous area of the skin, or just this upper surface of the skin, to reach some of those mast cells that have the IgE, the Y antibodies on them. And if that allergen it detects that IgE that matches, you have a histamine release there and what we call a wheel and flare reaction, like a little mosquito bite. So you get histamine released and you get a bump there. So that's how we do skin testing. And we can skin test to a lot of different things. The reagents that we use are made by a commercial company that they grow up all these pollens and everything, and then they have a special formula by which they pull the allergens out, concentrate it, and send it to us, and it's real expensive, and then we test with that. But, as I mentioned, IgE is also in the bloodstream, so you can also blood allergy test. It's a little bit different. It used to be called a RAS test, which involved radioactivity, radio tracers. Nowadays, it's an antigen antibody type of a test. It's a little safer, so most of these are done in-house. There are some weird ones that we send away, but most of these are done not in-house, my house, but my office, but in hospitals and things. So most of these are done at a local hospital or lab. One of the things that we do that a lot of allergists used to do and don't do anymore is nasal smears for eosinophils. What in the heck is that? Well, we have patients blow their nose in wax paper, and we take a sample of that, we dry it on a microscope slide, stain it with a special stain, and we can identify these cells called eosinophils, and they are markers of allergy. But they're not only just markers of allergy, they are the main effector cell, or the main cause of a lot of the symptoms in people's noses. So they're inflammatory cells. So these eosinophils are pretty important, and we call them allergy cells essentially. So we stain for those, and we can look for those. These tests that I mentioned will help rule out whether this is an allergic condition or not. What about treatment? Well, it's important. Some people will come in and they're like, why do I need all these tests? Well, we got to find out what you're allergic to so we can go full court press on how to avoid these things, because there's a lot of stuff to do if you are allergic. Avoiding the triggers. I mentioned about keeping the cats out of the bedroom and running a HEPA vacuum cleaner. When it comes to dust mites, you don't want feather pillows. You want to make sure you get special zipper covers that have this, the ones we like are just a very tightly woven fabric that kind of filters. It acts like a filter going around your bedding, so you're not breathing in dust mite particles throughout the night. So the covers are important. Keeping the pets out of the bedroom, running the HEPA filter, closing the windows, running the air conditioner. There's a lot of different things you can do depending on what you're allergic to. Now, what about treatment? This is an inflammatory condition, inflammation. The mast cells are there, the eosinophils are there. Nasal steroid sprays, and I'm sure you all have heard of Flonase, there's Nasacort, there's Nasonex, there's Rhinocort, there's a lot of different nose sprays on the market, but they work to get rid of the inflammation that is leading to a lot of this congestion, itching, running, that sort of thing. So nasal steroid sprays are a real important part of maintenance therapy for nasal allergy. It takes a few days for them to kick in and start to work, so a lot of people will use them a day or two. It doesn't open your nose right up and they just throw it down. But the way to use the nasal steroid sprays is to use them regularly. They're effective, they're safe. There are antihistamines. We know the histamine gets released from the mast cells, so antihistamines are very helpful, very important for the sneezing, the itching, the runny nose. There are lots of different pills. Older generation antihistamines like Benadryl and chlortrimeton and Atarax, those worked, but they were shorter acting and they really crossed into the blood-brain barrier. So they made you sleepy and groggy. The newer antihistamines are second generation, Allegra, Zyrtec, Loratadine. Those do not cross into the blood-brain barrier and therefore don't cause near the drowsiness. And they last for 24 hours. So a good 24-hour antihistamine, second generation, a good nasal steroid spray, and typically a good eye drop if people are having the eye allergy symptoms. There's a special membrane that keeps medicines that you take by mouth from getting into the eyes, so you have to use the eye drops for the eyes. But there are some really good antihistamine eye drops that are over the counter now that used to be prescription. One's Zaditor, one's Pataday. And finally, I'm sure some of you in here have heard of Montelukast or Singulair. This is medicine that's been around for a long time. It's not an antihistamine. It's not a steroid. It actually was initially developed as an asthma medicine because it blocks a special pathway called the leukotriene pathway. Well, leukotrienes are released from those mast cells, same with the histamine. Leukotrienes play a big role in the congestion, the drippy, and the itchy. So Singulair is indicated both for allergies and asthma, and oftentimes we'll use it in people that have allergies and asthma combined. But it's one of the other things that we'll use sometimes. And finally, when it comes to treating allergies, allergy shots. What is allergy shots? Well, with allergy shots, we take what you're allergic to based on your skin tests and sometimes blood tests. We put those items from the extracts into a serum. We dilute that serum down, and through a series of weekly injections, we get a little bit higher dose each time. And as we're building that concentration up in your shots, we're desensitizing you to these things in the environment. And this is what is known as a disease-modifying therapy, meaning if you continue to do these shots for a while, somewhere between 3 and 5 years, we can permanently downregulate your allergies. The other thing that allergy shots are helpful for is allergic asthma. We'll talk a little bit more about that too. So that is treatment for allergies. Now, it's important to keep in mind that about the vast majority of people that have asthma are also allergic. How do you tell the difference between an allergic asthmatic and a non-allergic asthmatic? Is whether or not they have positive allergy tests. If they're allergic, they have allergic asthma. Some of the toughest asthma to treat, though, is what we call adult onset non-allergic asthma. So it does exist. There is really good evidence because of nerves that connect the upper and lower airways and the inflammation that if we can keep the nose under control better, the asthma tends to behave a little bit better. There is a thing known as the United Airway hypothesis or the one airway hypothesis, meaning you got to treat one you can't leave one untreated to get good treatment from the other. So you have to really treat both of these things. Now, I mentioned the T cells earlier, but the T cell, the conductor of the immune response, is very important in this whole thing, whether it be nasal allergies or asthma. So what is asthma? Asthma is a chronic inflammation of the airways, or the bronchial tubes. And it takes a normal airway to one that is swollen, tight, and full of mucus. So there's really 3 things that go on with this. You get a thickening of the airway wall, that bronchial wall. You get smooth muscle fibers that are wrapped around the outside of that airway. They tighten and they kind of squeeze on the airway and further shrink that opening down. And finally, with asthma, asthmatics produce a very thick mucus because of those eosinophil cells. So you got airways that are full of mucus, they're tightened down, and the airway wall is thickened. And that is what causes the wheezing that you hear when you're listening to someone with asthma. It can affect all ages, babies all the way to older adults. It oftentimes starts in childhood, but it doesn't always. We have some people that develop it as an adult, and like I said, that's some of the tougher asthma to treat. Now, it's kind of a better, one of the terms that we use is twitchiness of your airways. You're very sensitive to certain things. These strong smells, perfumes, cologne, smoke, allergens. So your lungs are just kind of sitting there waiting to react to certain things. So that's because of the inflammation that's in there. So allergic asthma, as I mentioned, is most common. It is triggered by the allergens that we talked about: pollen, dust mites, pet dander, mold. It often starts with being allergic. One thing that I see, and it actually happened to me too, is people that are pretty allergic as teens, but not necessarily asthmatic. They get into their 20s, things get a little bit better, and somewhere around 30, it comes back, and oftentimes it starts in the lungs too. So you start having asthma at that point. But it's allergic asthma. So it can bounce around a little bit, but oftentimes people start with allergies leading into asthma. Non-allergic asthma is, even asthma, allergic asthma is triggered by these nonspecific respiratory irritants, but non-allergic asthma, there's no allergic trigger. It's all the nonspecific things, and it's due to inflammation. The eosinophils that are there with allergies are also there with the non-allergic asthma. So it can start later in life, and so asthma is one of these things that we got to get on top of. The whistling sound that you hear, and you might hear it across the room of someone who's really having a bad asthma attack, but you can hear it more subtly with a stethoscope in someone that's not that bad. The thing to keep in mind too, some people that are having asthma don't wheeze that much. They just cough because their airways are irritated. They're cough, 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 repetitive coughing. They are short of breath, and their ability to exert themselves is limited because of that. They'll complain of chest tightness. The important thing to keep in mind with asthma versus maybe COPD, which is chronic lung disease from smoking or other problems, is asthma is reversible. You can catch an asthmatic on a bad day and his lung function is down, and you might catch him on a good day and it's quite a bit better. Or you do a breathing treatment on that patient with albuterol, a medicine to reverse asthma, and it's better. So asthma is by definition reversible or variable. It can come and go. Now, this is a little shot of the allergic response that's kind of going on with asthma. The different triggers we talked about, the dust mites, the pollens, the pet dander, and then the non-specific things like smoke and pollution. You can see on the upper right-hand side of the diagram is a normal airway, nice and open. You can see it'd be easy to move air through that. And at the end are the little alveoli, the little air sacs. But wrapped around that airway is this what's called respiratory smooth muscle. And in the upper diagram, it's relaxed, it's not tightened. If you contrast that with the asthmatic airway, you can see that airway now, instead of being nice and open, is really tightened down. The airway wall is very thickened. There's mucus in there. Those muscle bands are tightened down. That's what we call bronchospasm. And so you can imagine trying to breathe through that versus trying to breathe through the open airways. That's why they have trouble breathing, and that's why they have exacerbations. So that is an an asthmatic versus a normal airway. When you're diagnosing asthma, again, history is important. Do they have good days? Do they have bad days? Are there specific triggers? Kind of like with allergies. Spirometry is a way to check how their breathing is, and it compares their breathing to where it should be for their age and their height. So it compares them to a set of normal values. Sometimes, what we're looking for, we'll do a breathing test, spirometry. We'll do a breathing treatment with albuterol and then repeat it. And if that improves around 12 or 15%, we'll know that they have what we call reversibility, and that is by definition asthma. Now, there's another test that we used to do, we don't do much anymore. It's called FeNO. That's fractional exhaled nitric oxide. That is a gas that is released by inflammatory cells in the lungs in parts per billion, I think. So very, very small amounts of that gas, but it can be measured by a machine. Insurance is kind of lukewarm on reimbursing for that, and the machine's expensive. So we don't use it a whole lot, but it is a sort of an indirect measure of the inflammation in the lungs. That can be helpful. Now, one thing that you saw on the table back here, what we call peak flow meters. These are handheld devices that patients can use to check how their breathing is. A lot of asthma patients have a disconnect, how they think their breathing is and how their breathing actually is. They think they're fine, there may not be that fine. So with a peak flow meter, handheld device, they blow as hard as they can, blast air out, and it gives them a reading. And then when they're good and not sick, they get a reading there, their best reading. And depending on that, they can watch. Typically before an asthma exacerbation, maybe a week before, those peak flows will start dropping off. And so that's a way that you can be proactive and knowing that your breathing is kind of heading south and you may need to get started on steroids or something else. So peak flow meters can be very helpful. And finally, back to this eosinophils again. We'll have patients, we have people come in and, they cough. We'll have them cough up sputum. We'll look at it under the microscope looking for those inflammatory cells, those eosinophils. Those are very helpful for us. And so we'll run into this a lot. People say, I've got COPD. They come in and they're coughing up a bunch of eosinophils. So that's good news. That tells you there's something you can actually do for them. I'm going to briefly go over treatment, but you're going to hear more about treatment from Adam here in a minute. Any asthmatic needs a daily controller, which is albuterol, and they carry that around with them. They use it if they need to. I'm sorry. Daily controllers are medicines that are used to control things. A rescue inhaler is one that you carry around with you and use as needed. The daily controllers are typically steroids coupled with a bronchodilator, and I mentioned earlier about Singulair. We'll throw that in there too sometimes. So it's a combination of those oftentimes. The quick relief inhaler, the albuterol, every asthmatic ought to have a quick relief inhaler. Now, what about these patients that despite using their medicines like they're supposed to, they're still having exacerbations a lot, and they're on steroids a lot? There are some very expensive, newer, very high-tech medicines called biologics that target a specific pathway in the asthmatic response that we'll use in those patients. And essentially, when you start patients on this, they come in and they always say the same thing: it changed my life. I mean, it really makes a big difference for them. So there are several of those, depending on what type of asthma you have. You've got to qualify. Insurance doesn't like to cover them because they're expensive, but they will cover them. And finally, allergy shots are very effective at blocking that progression into asthma over time if you're allergic. Or if you do have asthma, at reversing the asthma. So allergy shots, in the right person, it can be very helpful for allergic asthma. So briefly, we found out how you diagnose these patients, how you treat them. If you have allergies, we can lower their asthma flares if we're controlling that. We want to avoid the triggers. One thing I haven't mentioned, but influenza and pneumonia, respiratory viruses, RSV, they can really do a number on the lungs. So it's important if you have bad asthma to get these vaccines. I think they're very helpful. We have people that exercise, and they can use their rescue inhaler before exercise. That can help with your quality of life, if they keep you from the asthma affecting your breathing during exercise. And taking your medicines regularly is very important. We were talking a little bit earlier about being able to look at fill histories in the office when I'm talking to patients, and they will say, yeah, I'm using my asthma medicines every day. And I'm looking down at their fill history, meaning I can tell how many inhalers they've filled in the past 6 months. They may have only filled one, so something's going on there. But it is important. If you're supposed to be on an inhaler like that, do it regularly and regular follow-ups with your doctor. So when you're allergic, do you have to go right to the doctor? No. But if your allergies are getting to the point where it's affecting your quality of life, probably not a bad idea to see an allergist. If you're having a lot of nighttime symptoms with your allergies or asthma, again, see an allergist. One of the rules of thumb is if you're needing to use your rescue inhaler a couple times a week or more than that, that's a sign that maybe you're not well controlled and you need to have some change in your therapy. And obviously, if your asthma is bad enough to where you can't speak, then or hold a sentence, then you may need to go to the emergency room, call 911. There are some really good resources out there. There's a lot of misinformation on the internet about allergies, as you can expect, but the Quad AI, which is AAAAI, American Academy of Allergy, Asthma, and Immunology.org, and American College of Allergy and Asthma and Immunology, those are two really good resources, so you can access those. I think you can trust the stuff that they have to say. So I'll stop there and give it back to Dan.
Yeah, we really appreciate Dr. Clark. It was a wonderful overview of exactly what it is from a scientific standpoint to how to diagnose and how to treat, and as concise a presentation as I've ever seen. So again, we thank you. Our next presenter is Adam Purdy. I believe Adam is a native of West Virginia. He can elaborate on that if you wish. He graduated from Bridgemont and Carver in respiratory care and is a registered respiratory therapist. He has subsequently received his credentials as a neonatal pediatric specialist. He has been with the CMC Respiratory Department for 9 years and has worked at Memorial, General, and Women's and Children's Hospitals. Women's and Children's is now his home hospital, where he has worked in the NICU, the PICU, and the emergency department. 2 years ago, he became manager of the Women's and Children's Respiratory Department, and in that role has led many quality improvement projects. He's going to talk about the treatment of asthma and other allergic lung disorders. I'll give you Adam Purdy. Remember, write down your questions and make sure somebody picks them up.
Thank you for the introduction. Can you guys hear me okay? All right. So we're going to talk about asthma. We're going to just briefly discuss some of the signs of asthma, mastering the tools, and then what we can do to help our patients breathe better. Just disclosure, I don't have any financial relationship with any of the products in this slideshow. This is for education purposes only. So I graduated from WVU. I've been with CMC for about 14 years, including my externship. I'm a big advocate for respiratory therapy. I'm on the board for the West Virginia Society of Respiratory Care. I've also joined the board for the Asthma Coalition. It's been shut down from the state for the last couple of years, but they're trying to revamp and get that program back up and going. And I'm just a big respiratory nerd. I like the American Association of Respiratory Care. It's an international organization. It's been very eye-opening for me, and it's helped me throughout my career. But enough about work. If I'm not at work, I'm probably at the ball field with my two girls. And if I'm not at the ball field and I have time during the summer, I like to explore different parts of our state. So I encourage you guys, we have a beautiful state. Go out and see all of our state parks. I mean, I love West Virginia. I always ask folks, so what's your why? So respiratory therapy is important to me because you might know somebody or you might be directly affected by asthma, COPD, or lung cancer. And so one of the most satisfying parts of my job is I see patients come into the hospital in their worst moments. And I put my time and effort and energy in advocating for them, providing treatment, collaborating with nurses, with physicians, making relationships with the families. And over the course of time, I contribute to this patient going home healthy. I know I played a direct role in their care, and it's one of the most jobs, the highest, it's just very satisfying in my job. So just a quick recap on asthma. We know that it causes your airway to swell, which becomes more narrow. The inflammation may cause mucus in your airway and makes it difficult to breathe. So this is just a picture. The picture on your left is what a normal airway would look like. It's nice and relaxed. You have your smooth muscles. They're not constricted. You're able to get oxygen down to your air sacs and get oxygen into your body. During an asthma attack, those smooth muscles are going to constrict. It's going to make the airway very narrow, and it's going to make it very difficult for our patients to breathe. This is just another picture just showing you how narrow your airway can get during an asthma attack. The other problem we see is that you have the possibility of air trapping. So these patients can get air in, but they can't get air out very well. So if we were to get a normal x-ray on a patient, just they don't have any lung disease, we would like to see around 11 ribs on the film, but we'd like to really see about 8 or 9 ribs of lung expansion, okay? And at the bottom of this film, you'll see the little red lines that are curved, and that's just outlining your diaphragm. So your diaphragm is a muscle that contracts to help you breathe. And towards the end of those angles, you're going to see what we call claustrophrenic angles. You're going to see a nice curvature of the diaphragm. You're going to see your lungs pretty healthy here. If we were to get an x-ray of an asthmatic, we're going to see more black. So black is hyperlucency. That's showing me that this patient is obstructed. They have a lot of air. They're not able to get all that air out. And then when we look down at the diaphragm, these patients are going to be hyperexpanded. So we're usually going to see 10 or 11 ribs on expansion, and their diaphragm is going to be more flat. So we know hyperinflation is air trapping. These patients can get air in, but they have problems getting air out sometimes. they become short of breath and they become air hungry. So we know inflammation, it might be chronic or it could be triggered by how your airway reacts to the environment around you. So pollen, it could be exercise-induced, induced by stress, cold air, mold, smoke, pets, allergies, chemical fumes. Sometimes it's diet, the foods that we eat makes our body react certain ways. Could be triggered from a viral infection, pollution, and many more other sources. It can also be genetic. So anytime we have a patient that we're treating for asthma, we always screen the parents or we screen the patient to see if they have any family members with a history of asthma. If they react to the medication that we give them and it provides improvement of their symptoms, then a lot of times we know these patients are asthmatic. We're going to treat them as an asthmatic. We talked about some of the symptoms before, but we're going to see wheezing, shortness of breath, fatigue, chest tightness, chest pressure, and coughing. So some of the complications of asthma is that if we cannot get it into control, we see patients go into status asthmaticus. So they're in a major flare-up and they have a major difficulty of breathing, and when they can't breathe, they're not able to get oxygen into their body, and these patients could really go into respiratory failure, so it's very serious. So how do we control and treat asthma? So we'll talk about some of the medications that we can give. There's different delivery devices. A lot of asthma and education around asthma is we want our patients to be self-aware and understand. That way they're not at a point where they're crashing and burning. And education and family support is very important. So medications, there's a lot of medications out there. We'll kind of break down each type of medication and how they work. So you have your short-acting beta-2 agonists, or what we call, in medical terms, SABA. And so these are your rescue drugs. They're quick-acting. So you're going to see albuterol, Broair, Preventil, Ventolin. Those are some of the names. I'm sure these might be common and you've heard them before, but they're going to relax your tight muscles in your airway and offer quick relief of your symptoms. Okay, then you have your long-acting beta-2 agonists. So if you're not getting relief with the short-acting rescue drugs, you might be eligible for the long-acting drugs. So you might have seen these around, or heard them, or watched commercials, but Brovana, Servant Discus. Then you have your inhaled corticosteroids. So these are just steroids. So this isn't a rescue drug, but it's going to help prevent swelling and prevent flare-ups. So we call these our controller medications. A lot of times patients that are prescribed this, depending on the severity or how chronic their lungs are, they might be required to take this daily, or they might be prescribed to take it on the onset when they become sick and take it for a certain amount of time. But some of those drugs that you might see there would be Flovent, Pulmicort, Butanazide, and Qvar. Next you have your anticholinergic or short-acting muscarinic antagonist, which we would just like to call SAMA. So these are your backdoor bronchodilators. So these medications, they block receptors to your acetylcholine, and so that allows smooth muscle to relax in the event of a bronchospasm. A lot of times we give this drug in addition with albuterol, and we give it together. But some of the names for those drugs are Atrovent, ipratropium bromide, and Spiriva. Then you have your controller medications. So these are going to be for your patients that are more symptomatic or patients who have more chronic lung disease. So you have Advair, Symbicort, and Dulura. So that's your LABA plus steroids. We do LABA and LAMA. Bevspeed might be a drug that you've heard of. We have LABA and LAMA plus a steroid, Trelegy, Ellipta. And then the most common drug that we give in the hospital for status asthmaticus is our short-acting drugs with SABA and SAMA. So this is Duaneb, so that's the combination of albuterol with Atrovent. It can also be given nebulized or via meter-dose inhaler. Some of your more advanced drugs, so you have your PDE4 inhibitors, so these block enzymes that prevent inflammation. You have your biologics. This is an injection. They target cells that cause airway inflammation. And then your leukotriene modifiers, they block chemicals to prevent airway inflammation. Dr. Clark talked about Singulair earlier. So what's best for you? That we have all these drugs out here, but really you need to see a specialist. You need to consult with your primary care physician. You need to consult with a pulmonologist. It's really important for you to understand your symptoms and to explain your symptoms to your specialist. That way they can find the best treatment for you. Dr. Clark also talked about spirometry testing. So we can do pulmonary function testing, and we can look at your lung volumes, and based off these findings, we can determine if you have obstructive lung disease, restrictive lung disease, or just any type of reactivity of your airway. And a lot of times when you're placed on a medication, we might trend pulmonary function testing over the course of time to see if your lung volumes are getting better. If your lung volumes are getting better, we know these medications are working. We're going to stick with this plan. If they're not working, we're going to look for alternate solutions to help you out. So just really recognizing the warning signs. So shortness of breath, audible wheezings. In the hospital setting, wheezing in my book is actually not a bad thing, because if we hear someone wheezing, we know that they're moving air. If you have a patient that's asthmatic and you listen to them and they have work of breathing and they have absent breath sounds or diminished breath sounds, that's when I start to get worried. They need urgent care because they're not moving any air at all. They need rescued. These patients, they get so short of breath they can't talk. If they start to use their accessory muscles, so if they start tugging their shoulders just to take a deeper breath, if they're nasal flaring, if they're using intercostal muscles around their rib cage, any type of extra effort, they're struggling to breathe, they need assistance. And then a lot of these patients, they may turn blue at the lips, they're not getting oxygen into their body. So understanding asthma, so there's 3 different zones. There's green, yellow, and red. So your green zone, this is your clear zone, so this is where you should be at every day. These patients can perform daily activities without any issues. They're not coughing, they don't have any wheezing. Depending on what they're prescribed, they might be required to take medication, whether that be daily for preventative use or before exercising. But these patients are good. This is where they should be at every day. Your yellow zone is the caution zone, so this is where you should not be. This is, in this zone, you need to recognize if patients are coughing, wheezing, shortness of breath, or have chest tightness. They're not able to perform daily activities. They have issues sleeping, they're restless. You need to act immediately and take medications prescribed to control your symptoms. We want to be back in the green. And then your red zone, so this is your medical alert zone. This is an emergency. This is where you need to either call a family member, you need to call a doctor, you need to see what your asthma action plan is for rescue medication. So these patients are short of breath. They don't get any relief after medication. They have trouble talking, walking, and they're not moving very good air. So you need to get help right away. And so when we discharge patients from our hospital, we give them an asthma action plan. So it's a stoplight report. And so we have what their symptoms should be in the green zone. And then we usually, on the right, we'll write down what medications they should be taking and how often and which form of, if they should be taken via nebulizer or inhaler. Your patients that are in yellow, this is where we have an action plan of, okay, maybe you take albuterol 2 puffs when you're in the green zone, but you're in the yellow zone, you need to take 4 puffs of albuterol, right? And then in the danger zone, so this is more of your rescue route, and make sure that our patients know that once they're in the red, they need to be calling for help. We talked about peak flow meters earlier, but this is a great device, especially for kids, because like I said, some kids may ignore their symptoms. Sometimes, we look at compliance. A lot of kids don't take their medications a lot, or sometimes parents don't give kids medications. A peak flow meter will keep you honest with the status that you're in. So it's a little device, it's handheld. You rapidly blow into it, and it measures flow in liters per minute. Sometimes patients might be required to take this daily. Sometimes they're only required to take it before and after breathing treatments. It depends on what your specialist has planned for you. And then Everyone breathes different lung volumes, so we have different goals for everybody. So it's usually based on height, age, and sex. There's different peak flow meters out there, so I just showed a couple different pictures of what they might look like. Each one has a pamphlet that comes out with it, and you just follow your age, and then you follow your height, and you match it up on the graph, and that's going to give you your target volume or your target flow. So with your peak flow meter, you can highlight it in color, and so your green is 80 to 100% of what your personal best effort should be. The yellow zone is going to be 50 to 80% of your personal best, so your asthma is not under control. You need to take action and treat. And then the red zone, so this is less than 50% of your personal best. We need help. We need to take action. Now let's talk about some of the delivery methods of medication that we can take at home for asthma. So we can take inhalers. So we know inhalers are small, they're portable, they're lightweight. It takes less time to deliver medications because they're pretty quick. The medication delivers directly to your lungs when you inhale it in. The particle size of inhalers of the aerosol is very, very small. Therefore, it deposits and travels deeper into your airway. It is very effective. Now, what are some complications of inhalers? Well, we know that the medication does deliver very, very fast. So patients may not be able to coordinate taking a puff and taking a breath in at the same time, or they might be doing it incorrectly. And a lot of the research and literature shows that that medication actually gets deposited a lot of times in the back of your mouth, the back of your roof of your mouth, and it's not going down into your lungs. So how do we fix this? We fix it with spacers. So spacers is a little chamber, and it has a one-way valve on it. And so you attach your inhaler to the end of it. You take a puff of your medication. Before you do that, you should seal your lips around the mouthpiece. It has a one-way valve, so you puff the medication. The medication is collected in that chamber. You take a breath in. The aerosol goes down into your lungs because it's triggered by flow. It has a one-way valve. It's not going to go to the back of your mouth. We, at my hospital, we give this to all of our pediatric patients, and we also give it to all of our adult patients. So when you take it, you want to shake your MDI canister prior to use. You want to attach it to the holding chamber. You want to be sitting up or standing up, right? If you're laying down, gravity is working against you. You may not take a good breath. You're going to seal your lips around the mouthpiece. You're going to administer a puff. You're going to inhale slowly for 3 to 5 seconds, okay? Once you've taken a full deep breath in, you're going to hold that breath for about 5 to 10 seconds. If you take too fast of a breath, that little chamber is going to whistle at you, and that's actually a safety call. So it's telling you, hey, you're breathing in too fast. On the next puff, the next medication administration, you might want to slow that breath down a little bit. And then if you're required to take more than one puff, you just repeat the steps. You can also give MDI spacers by mask. So we actually introduced this to our patients in the hospital that are infants and have chronic lung disease, right? Because if they're in a situation where they're out with their family, out with their parents, and they need assistance with their breathing, you're not going to have a portable nebulizer machine with you. The MDI, it's small, it's portable. You can place a mask over the patient's face, and it's very effective. It's the same process of getting it positioned right on the patient. You want to make sure the mask is sealed. That's the most important part with these kids. Make sure it's sealed around their mouth. You're going to give a puff, and you're going to allow that kid to take about 5 to 6 breaths. Because at that point, they're breathing in and out. They're going to get that medication in. And then if they're required to take another puff of medication, we just repeat the same steps. So you'll see different mask sizes. So this is just an example. But you can even give it for adults. And the one thing with this too is we've introduced it more for our smaller patients because now they're not going to get the fear factor of this and they're not going to be scared. You're introducing it early into their lives. You're trying to keep up with it, and you're not going to have issues down the road with compliance. This is just a picture illustrating just how effective it is to use with the spacer versus not using it with the spacer. So you can see without the spacer, that medication, a lot of it is in the mouth and it's not going down to the lungs. But with the spacer, whether it be by mouthpiece or with mask, it has more deposition to the airway and it is more effective. And so you have the option of using inhalers. They're very portable. They're very common to pick up at pharmacies, but you do also have the option of using a small volume nebulizer if you want to use a nebulizer machine at home. And so it's basically just a small air compressor that typically delivers flow about 5 to 8 liters. There's a little nebulizer cup that we put the medication in that typically holds 3 to 5 milliliters of solution. You might also hear this as small volume neb, but you might also hear people call it a jet nebulizer. So it creates a high velocity of pressure that generates that flow to create aerosol particles. You can give this by mouthpiece or mask, and it typically takes about 10 to 15 minutes of therapy time. So when that flow is traveling via tubing into the nebulizer cup, the pathway becomes more narrow. That's going to generate more pressure. That's going to cause that solution to aerosolize. That aerosolation with the flow is going to go up the cup, either into the mouthpiece or into a mask. And then for kids, we don't want them to be scared of this either, so we try to find all the kid-friendly nebulizer machines out there. I believe this is Sammy the Seal. So nebulizer instructions, you want to assemble the cup and follow the instructions, place the correct medication and amount in the nebulizer cup, insert tubing to the machine and turn it on. It's best to use mouthpiece, so if you can coach a patient to do a mouthpiece treatment, that's the best way to receive medication. If they're not able to effectively breathe by mouthpiece, then we want to introduce an aerosol mask to them. But if you're doing a mouthpiece treatment, these patients, you're going to start the therapy. They're going to take normal breaths in and out through their mouth. We want to see the aerosol and the smoke in the nebulizer tubing go in, and we want to see it go out as the patient's breathing. And then once about every 30 seconds, we usually instruct our patients to just take a big deep breath in, right? We can't instruct them to take a big deep breath in every breath because they're going to get really winded and they might get fatigued and pass out. And we tell these patients to continue breathing this medication until the aerosol is no longer visible. If you hear it starting to sputter, just kind of shake it a little bit. We don't want to be wasteful. We want to use up all the medication in that nebulizer cup. So I'm going to talk to you guys about a different form of nebulizer. So this is a vibrating mesh nebulizer. We use this a lot in the hospital, and it's starting to be used in home care. And so it is not generated by flow or by gas. It's generated by electric. And it does not need oxygen. So how this works, it has a little metal plate in the nebulizer cup, and you place the medication in there and you power it on, and that little metal plate vibrates very, very rapidly at high frequencies, and it creates very, very small particles of aerosol. And so we talked about the inhalers being small particle sizes, and it's going to travel deeper into your lungs. So the particle size for a vibrating mesh nebulizer is about 1 to 5 microns. Sometimes it's smaller than naked eye. It's very difficult to see. In use in the hospital, it is shown to deliver 6 times more medication at deposition versus a jet nebulizer. And they can also be delivered mouthpiece, aerosol, or mask. And so the picture on your left is your mesh. It's handheld. It can either be plugged into the wall or it can be powered by battery. Very comfortable to use. And then your jet nebulizer, you have limitations with it just because it's a little bit bigger, bulkier, and you have to plug it into a wall. So the future of vibrating mesh nebulizer is right now insurance will approve it for home use, but only if patients are using it in line with a ventilator. Insurance right now will not cover it. The handheld devices, if you're going to purchase one at the moment, it's about $400 to $600. But one of the vendors that I've been in contact with, they're working on getting FDA approval, and insurance soon will be allowing patients to go home with these vibrating mesh nebulizers. And I think this is the future because there's a lot of literature and research in the hospital showing that especially for asthma, is that patients that are on the vibrating mesh nebulizer, they receive less treatment time and they receive less treatments to reduce the symptoms of their severity. So it's very efficient. And so we have all these tools in our toolbox, so it's really important for us to advocate and understand which tools that we use to treat asthma. And so I'll just share a little snippet of a project I'm working on. So I'm doing a clinical pathway for asthma management at Women's and Children's Hospital. And so I've developed a asthma score, and based off this score, it's going to trigger which medications to use on these patients, how much medication, how often, and it's also going to trigger which nebulizer type to use, right? Because we talked about the small volume neb. The vibrating mesh nebulizer is very effective. We're going to start using this more in our practice and see what kind of outcomes we have with it to see if we can reduce length of stay, see if we can reduce severity of asthma and get these patients better quicker. But with equipment, follow your manufacturer instructions. A lot of times you want to just wash your nebulizer cups, you want to wash your spacers. A lot of times the spacers, you can take them apart. It's recommended to wash daily, just warm soap and water, let them dry. It's really important, especially if you're using a spacer or nebulizer cup with any type of steroid, because if you don't clean that out, it's going to create thrush and fungi, and we don't want to get that into our bodies. So that was some of the medications that we take, and then we talked about some of the ways that we can deliver these medications, but there's also some things we can do to help our breathing. Something that's really not new and it's been out there for a long time, but it's just purse-lip breathing. So allow patients to sit upright or stand. You're going to instruct them to take a deep breath in through their nose and exhale slowly through their mouth. If these patients are short of breath, this is a good way, because if you're short of breath, you're probably going to have a little bit of anxiety. You're going to be panicking a little bit. So we need to get these patients calm and relaxed. So I actually use this breathing exercise a lot at my girls' coach pitch and player pitch softball games, because these girls, they get upset very, very quickly. Well, this just helps slow your breathing down. You can also do diaphragmatic breathing exercises. There's a couple different ways you could do it. You can either lay down or you can stand upright. But basically, you're just placing your hand over your stomach and your chest, and you're just really focusing on not using your shoulders to take a deep breath. You just want to take a deep breath in and a deep breath out, and just understand how that feels, and try not to use any of your accessory muscles to take a deep breath. So your asthma checklist. So it's really important to give information. So tell somebody, especially for a kid, but explain all your symptoms. Your physician or your specialist, they need to be investigative. That way they understand the information that you're providing to them, that they can treat you the best way possible. Follow directions. If you're given an asthma action plan, it's important to be compliant with that. Use that daily. Don't skip a day. We were talking earlier about in the summertime, when sometimes there's less triggers of allergies or pollen outside, and these asthmatics, they feel like they're okay during the summer, and then school pops back up, and now they're exposed to other environmental triggers, and their asthma flares back up. And provide information. So if you have asthma, or if you know someone with asthma, it's important for you to tell others, hey, I have asthma. If something were to happen to me, this is what we need to do. So have a plan. Educate others. And advocate. So it's really important in my profession that we teach patients how to properly use the peak flow meters, how to properly use their medications with a spacer, and how to properly use their nebulizer machines. That's all I have for you guys today, and I appreciate your time.
Thank you very much, Adam. Very comprehensive. And now we're going to, if you all have questions, we may have a few enough people just to simply, to ask questions of them individually. But Jim, if you could come up and have a seat there, I'll take the moderator's prerogative, maybe ask a couple of questions to get things started. And we'll
job.
see how many questions we have. Well, I'll take some that were written, and then we'll probably take a few from the floor. But thank you so much. That was wonderful. Thank you, Stacy. Let me ask, intense allergic reactions or severe allergic reaction, like anaphylaxis. We have oropharyngeal swelling, and they're life-threatening. Can you all speak to that? And what, obviously some of that can be a life-threatening emergency.
I can take that for starters. So a severe or anaphylactic allergic reaction is when typically it's histamine mediated. You've come into contact with something, whether it be, we'll use the example of someone who's allergic to a food like peanuts, and they ingest those peanuts. And so now they're allergic to the peanuts. So the peanuts come in contact with the mast cells in the gastrointestinal tract, and immediately you're getting tons of histamine being released. So what does that do? Well, there are several things. It causes swelling. We saw where it causes the blood vessels to swell. It causes mediators in your main blood vessels to swell too. So your blood pressure's here, and now it's dropping. And so you can be shocky. So your blood pressure can drop. It leads to bronchospasm in your lungs. So your airways, instead of open, are now tightened down. And so it's sort of a multi-symptom condition that can be very life-threatening, and it's treated typically, epinephrine or adrenaline is a good way to shut that off, and that's why people that have these systemic reactions typically carrying around an EpiPen. Epinephrine is quick to lead to bronchodilation, so open those airways back up, relax those smooth muscles around the airways. It's quick to tighten up your blood vessels, so run your blood pressure back up too. And so it's quick to reverse some of these symptoms. Severe allergic reaction, anaphylactic reaction can be very life-threatening. Now, another thing to keep in mind with these, I mentioned a little bit earlier about you have an immediate allergic response and a late phase allergic response. And it can be what we call biphasic here. There's two of them. So epinephrine helps to control that immediate hypersensitivity reaction, and hopefully one bit of epinephrine is enough. But I always tell patients, if you have to use epinephrine, you're on your way to the emergency room, because that can wear off and you might need to use another one. But also, the mediators that are released during that allergic response, some of those are slow to act, like leukotrienes, for instance. Their old antiquated term was slow reacting substance of anaphylaxis, because they were preformed and they came out, but they were slow to kick in. But they're much harder to control, and antihistamines don't help with that. So you have this late phase allergic response, and oftentimes steroids are important for that. So you got to watch these people that have had an anaphylactic reaction. So treating the immediate phase, use epi on your way to the emergency room, where you're monitored, maybe given more epi if you need it, but monitored for any of these late allergic reactions. And there's all sorts of things that can cause that. I mean, one of the things that probably everybody in this room has heard about, and we've been inundated lately, is called alpha-gal syndrome. And this is this crazy thing that we've probably seen for the past 15 years, and we're kind of ground zero for it here. There's a special tick called a Lone Star tick, which is sort of a medium-sized black tick with a white dot on its back. And I live down in Winfield, and it is crazy. I'll go out in my backyard. I've got some woods back there. I'm in there for a short period of time, and I've got these ticks on me. And I grew up around here, and I never saw ticks like that. Anyway, why that tick's important is a percentage of people that are bitten by that tick, the saliva in that tick can initiate an immune response in that person to make antibodies that we talked about, IgE antibodies, to alpha-galactosidase galactose, which is a carbohydrate that happens to be hooked onto mammalian products, beef, pork, lamb, milk. And the problem is these people that get that antibody, if they eat beef or pork or lamb or milk or venison perhaps, they can have an anaphylactic reaction. The weird part is it doesn't happen until hours after they eat it. So the classic presentation is these people wake up in the middle of the night in full-blown anaphylaxis. They're like, where did this come from? And they wind up in the emergency room. And after we look into it a little bit deeper, they had steak dinner or something like that. So This is one of the things we've seen a lot of lately. We're diagnosing maybe a couple people a week with this, in the office, maybe more than that. And so once you get that antibody, it can go down over time by itself, but the key to that is to not get more tick bites. So it's very important. If you're out in the woods, we all like to get out in the woods. Anything you can do, DEET-containing products to prevent that from getting those tick bites. But tick checks once you're out of the woods and make sure you don't have them. I picked one. I had an embedded one on me earlier this year, and I've got my fingers crossed that I don't get this thing. But it's very, very, very weird. We're seeing a lot of that lately.
Thank you. Question maybe directed more to Adam, and of course you can chime in too, Jim. What percentage of children, and this may be a difficult question, typically will outgrow asthma? Is it the most common presentation or pathophysiology of the disease, or is it not that common?
Probably closer to your
I mean, that's a good question, and they did a study several years ago called the Tucson Health Study, because we know that some kids, when they're younger, they wheeze and they have asthma, but then they grow out of it, and some don't. And so they looked at these early wheezers, and they found out that typically, if you wheeze when you're young and you get allergy testing, and your allergy tests are negative, you've got a good chance of growing out of it. By the same token, if you are wheezing and your allergy tests are positive, then you've got a good chance of probably not growing out of it. And what that boils down to is respiratory viruses like RSV is a real big trigger. RSV we used to think caused asthma, but it really doesn't cause asthma. It causes you to be asthmatic for a period of time, and then you'll eventually grow out of that. But other respiratory viruses can do that too. So it really depends, and if they're really allergic, there's a decent chance they're probably not going to grow out of it, or it'll maybe get better as time goes on. But if they don't have positive allergy tests, there's a good chance they will not have asthma as they get older. So allergy testing is pretty important in that respect.
Okay, thank you. There's a couple questions here. What is sports-induced asthma?
It's just induced by exercise because you are using your diaphragm more, you're breathing more rapidly. Sometimes that's a stress reaction to where it's going to cause bronchial constriction to those airways. So those patients, if they're symptomatic and they're short of breath, their airways tight during exercise, we want them to, one, be aware of that, two, let someone know about it. And we got to get them under control. So what's going to help prevent symptoms? What's going to help control those symptoms? So a lot of times we want them taking their rescue medications before they exercise and just following through with that.
Another question, does Women's and Children's treat inpatient and outpatients?
Yes, yeah, we have a pulmonary clinic. Usually it just depends on their schedule, but Monday through Friday we hold a clinic. In the hospital, we'll accept anybody. So in my job, we see a lot of asthmatics, a lot of patients that have asthma, or it's more viral related because we see a lot of viruses. We were kind of talking earlier, we used to see a common trend with viruses. So you should see a lot of patients that were viral during school. When school would start up, you'd see a lot of patients come to the hospital. But since COVID, things have really changed, and the trends have been differently. This was actually, 2025 was actually an odd year for us because we did not see a lot of viral patients in the fall, and that continued to be like that in early winter. And then we had a big uptick in February where we saw a lot of RSV. That's when we really started to see our viruses. And right now we're starting to see more of our patients with asthma-induced symptoms with viruses. One common virus that we see all year round is picorna. It's rhino and entero, but we're seeing a lot of it right now.
So is there a walk-in clinic, or you don't have to go through the emergency room for?
So the outpatient clinic is in our medical office building. We will have to set up an appointment, but we have phone numbers available. And you can call the clinic at any time and get a consult placed. We have 2 dedicated pulmonologists at our hospital.
Okay, thank you. Are there other questions? Yes. Let me give you this.
You mentioned
Yes.
Is that the same as a patch test?
No.
Cleveland Clinic?
That's a good question. Prick skin testing is where that little bit of allergen is introduced into the skin by scratching the skin. They're also called scratch tests. And then to see if it comes in contact with the mast cell with the IgE antibody, and you get a wheel and flare reaction, immediate reaction. Patch testing is more for contact dermatitis. So patch testing is testing a different part of your immune system, the cellular immune system, the T cells directly. And so the contact dermatitis, the prototype for that would be something like poison ivy, where you're exposed and it's not until a day or two later you're starting to get itchy because of the pathway that it goes through to get to that itchy rash. It involves the Langerhans cells and pretty technical stuff in the immune system to finally, for that Urushiol oil, which is the poison ivy oil, to lead to a rash, and that is delayed. So contact dermatitis is often like that. You are exposed to some chemical or metal or something else, and it's not until later that you have the reaction. So the way to test for that is patch testing, where we use a commercially available test kit called TrueTest. And TrueTest has 36 different common contact allergens in it. And that is found in 3 pieces of tape about the size of a dollar bill. And those pieces of tape get stuck on your back. And they stay in direct contact with your skin on your back for 48 hours, trying to elicit a response from those Langerhans cells to then lead to a little irritated area on your skin when we peel those off. And so that's patch testing. Patch testing looks for contact dermatitis, skin rashes, versus prick test looks for immediate hypersensitivity, like nasal allergy, that sort of thing.
Others? We got one other. Bee stings. Is the allergic reaction dose related in the sense of how many bee stings and the amount of antigen that's involved? Can you speak to that, either one of you?
That's a good question. So, a lot of people will come into the clinic and they're like, I want to be tested for bees. Well, have you had any problems with bees? No. Then it's really not any indication to be tested for bees if you haven't had a problem. But with bee sting allergy, you have to be stung at some point, and then your immune system makes those IgE antibodies, and then it goes and rests on the mast cells again, and they're just sitting there waiting. And there's a little bit of a misconception that each time you're stung, it's worse. It's not necessarily worse, but it can be. So once you are stung and you happen to be unfortunate enough to develop antibodies to that venom, it's venom, and you're exposed again, then you can have an anaphylactic reaction. And it can, there are some people that just go right to their blood vessels relax, they get shocky, they pass out, hives, difficulty breathing, that sort of thing. And it can be dose related. Say, if you get into, growing up, I cut a lot of grass and would get into a yellow jacket's nest with a mower, and by the time you realize you got one yellow jacket, you're getting stung by 10 of them. And so, you can have a more severe reaction if you're stung by more stinging insects if you're allergic to it. Now, sometimes if you get this mass envenomation where you're maybe getting a yellow jacket's nest and you get stung 50 times, you can get a toxic effect in your bloodstream from all that venom, but it also is more common to trigger antibody reactions down the road. So we tell people, the big difference, a lot of people will get local reactions. They're stung, and over a period of hours to days, they get a real big swelling. That's called a local reaction or an exaggerated local reaction. And that is not life-threatening, or too much concern. But it's the immediate hypersensitivity reaction where you're stung and within minutes break out in hives all over, get tight in the chest, feel like you're going to get, pass out because you're getting dizzy. Those immediate symptoms, those are the dangerous ones. If you have that, you should be tested. We can do, traditionally we have done skin tests for stinging insects, but the extract that we use are on national back order, so we have to resort to blood tests for that. But we will do blood tests, and venom allergy shots are very effective at preventing subsequent bee sting reactions if you are one of these people that has that. So we give a lot of people bee sting shots.
Thank you. Are there any other questions? If not, I want to thank our expert panel for a wonderful presentation. And I'm sure if you have some questions that you would prefer to ask in private,
Sure.
they'll hang around here for a few minutes to answer those. That's often a situation that occurs. I want to thank Stacy Cavender and Jay Ripley for all the work putting this together. And I hope you all will fill out the surveys for us. They are incredibly helpful. It may not seem that way, but it does make a difference in terms of topics we want to consider or just the way the program was run. But again, thank you so much for coming. Hope it fulfilled your needs. And there's still some beautiful weather out there. Enjoy the rest of the evening. Thanks.
There's certificates on this
Oh,
table
I forgot
right
that.
here. Yeah.
There's certificates, I forgot. Certificates for suitable for framing, for completing the mini-med school. Thank you.